Hello, everyone, and welcome to another Global Diabetes Insights episode. I'm super excited today because we have two very important personalities of both diabetes community, but also IDF, Dr. Taki Maalouf and her daughter, Sylvie Maalouf. So before starting, would you like to introduce yourself?
Thank you. Thank you so much. Well, I'm Sylvie Maalouf. I'm a co-founder for DiaLeb along with Sylvie and currently serving for a second term as a vice president with the International Diabetes Federation with a long experience by now in advocacy, in public health policies. And I'm currently also serving on the board of the NCD Alliance. So this gives even a wider scope. Sylvie?
Hi, good morning, and thank you for the introduction. I'm Sylvie Maalouf. I'm a co-founder with Jackie, who's my mom, just FYI. I am policy advocate and policy expert, having worked in many places from the World Bank to government to now with the Qatar Foundation here in Qatar. But most importantly, I'm a great person living with diabetes since 17, almost 18 years. I'm very close to the anniversary mark. So yeah, it's 18 years almost. Also working very closely with our programs at DiaLeb. It's a pleasure to be here and speak to you today.
It's our pleasure to have you here. I will start with Dr. Jackie. I know that you started with a background of academia and public relations, and then you moved to DiaLeb after Sylvie's diagnosis of diabetes. So I would like you to answer how you found purpose from moving to such an academic background to more, let's say, realistic and relationship programs and to build a community. How was the transition for you and how you found yourself in founding DiaLeb?
Thank you. I often get asked this question, but there's one simple answer that life has sometimes those moments when everything you thought was permanent and fixed suddenly shifts. It's mostly up to us how to adapt and how to take it in a positive way. So for me, it was Sylvie's diagnosis that happened, yes, suddenly. Whatever I was doing at that moment and my PhD that I was so proud of made me feel like there is so much I don't know, and there is so much I need to learn, and there is so much I need to do, especially that her attitude was to me a guide. Maybe it was supposed to be the other way around. I don't know. I'm simply being completely honest about it. She was diagnosed at the age of 24, a young lady who had enough wisdom in her reaction to her diagnosis to teach me a lesson. I have to say also, those days were a bit of a roller coaster. I had the fear of social stigma. Maybe a young person doesn't realize that, but as a mother, I had to think of so many things that maybe never crossed her mind at the time. Now she understands it much better because we live in an area of the world where social stigma is still something we need to worry about. Also, there was the confusion over conflicting information, the fear of the unknown in my case, because it's an enemy, let me say, that I know nothing about. How can you fight an enemy without knowing its weak points, its strength? That's how I see it. But I quickly realized that if I could do something to other families, to be their voice, to avoid this confusion that I as a mother felt. And we had this discussion with Sylvie, and she was really keen of helping others. So that's where DiaLeb was born. But the hardest mindset shift was probably to me accepting that this wasn't a simple detour. It was completely a new road. But when I did accept it, it was a heartfelt mission, and all my positivity, all my energy that God has been generous giving me, I put it to the service of this newly born organization, along with Sylvie, to structure its programs, to think of every single person living with diabetes, first in Lebanon, our community, broader the scope of our work later on. So everything becomes like my skills that I had prior, my years of experience as a public relations specialist, my years of teaching at the American University of Beirut, at the AUCE, were all at the service of this mission to do a better job. And as I said, avoid, if we can, other families from feeling lost, which is the place where I was at a certain point.
Thank you for this answer. I think it to the hearts of many parents nowadays, but also we have to think about how difficult diabetes was almost 20 years ago, how less of equipment we had, how less technology was advanced. So the stress of a parent at that point was really, really high, and the danger of a child living with diabetes was real for something to happen. So you not only belong and have founded DiaLeb, you are the vice president of IDF, International Diabetes Federation. You have a holistic approach and a good knowledge of diabetes and the map and the worldwide map of diabetes. But I would like you to take us through some blind spots when it comes to type 1 diabetes and the way the world perceives it.
That's a good question. Thank you for speaking about the blind spots. And definitely there are several. Let me just say that when I was elected for the first time as vice president at the International Diabetes Federation, I was actually the first woman from our region, the Middle East and North Africa, to occupy this position. And now I'm serving my second term because I was re-elected for this position that I really take to heart as we develop strategies, as we serve the community of people living with diabetes. I always say it's a learning process to all of us. No matter how much we know or we think we know, there's always a lesson to be learned, especially from the people living with diabetes. And now we talk a lot about it, that we can never do any strategies, any policies. We should never speak about those without the people living with diabetes sitting at the core of the decision-making table. And I think we've advanced somehow in this process, but yes, we do have many blind spots. But let me first tell you that when I started working at the board of the International Diabetes Federation, I saw something that shocked me. I saw how geography dramatically dictates this destiny of people living with diabetes. I'll explain it a little bit further. Like a child can be in one country thriving for its future because insulin is a routine, care is a routine, everything is accessible, affordable, well taken care of, where another child with the same living condition as related to diabetes can be thriving to really survive the month because insulin is not affordable enough, is not available enough. The care, the regular routine checkups are a struggle. So this is not a lack of science. Unfortunately, science has advanced a lot. Unfortunately, for those people living in those parts of the world, it's a lack of access and of attention. And those are the main blind spots. But I will speak a little bit further, if you allow me, about it. With all these that we have in technology, smart pumps, data platforms, but if the family cannot afford the insulin or receive basic education, this is like science fiction. We're talking, and nobody is implementing what we are talking about. The three main blind spots at, let me say, at a global level that I would like to tackle is first, still, the misconception that type 1 is lifestyle disease just like type 2 and creating a guilt feeling without even thinking about it and diminishing the urgency because type 1 cannot wait. You both know you are living with type 1 diabetes, but we need the audience who will be listening to this podcast to really understand when we talk type 1 diabetes, there is an urgency. So that's one. Two is the access, which remains unfortunately inequitable. Even 100 plus years after the discovery of insulin, we know that there is no equity in that regard. It remains not reliable to obtain in many, many places. And third, the primary care systems are often not well prepared. That gives room to delays in the diagnosis or sometimes mismanagement. Bridging those three main gaps that I spoke about requires universal recognition of the urgency, especially knowing how diabetes is related to other NCDs. And I mentioned earlier, serving currently for 2 years on the NCD Alliance Board, it's related to many other NCDs. So if we give diabetes the attention and the urgency it deserves, this will help us prevent not only diabetes, or manage well not only diabetes, but prevent many complications related to many other NCDs. But we'll finish this idea by reminding us all, I always include myself, not to be a lecturer, but to just spread the positive words about this, that insulin access and the education, the basic education, are simply human rights. Those are not privileges. If we remember that, I think it will help us a lot when we are working strategies and thinking public health.
Thank you so much for the structured answer. I truly believe that what you said is what the world experiences when it comes to type 1 diabetes. I always say that the treatment mostly a result of accessibility. Nowadays, with the progress of technology, the person with diabetes doesn't have to do as much as to get used to the technology. So also just taking the box that the country has test strips and pens for people with diabetes doesn't mean accessibility. It means that we keep those people alive, but in terms of quality of life, we are far behind when we just give the bare minimum to people living with diabetes. You mentioned that you are the first woman of MENA region to being in such a strong position, and I congratulate you for that. I've wrote in it, you've often spoken about women needing to ignite from within and not expect support. How this philosophy has shaped your leadership, or has your leadership shaped this philosophy, and how difficult it is to be a woman is such a leading role nowadays, but also back when you start this journey of advocacy and of human rights when it comes to diabetes.
Yes, everyone, I think, who knows me, and not recently, who has known me from before, they know I'm a positive person. I do have a strong personality, and I firmly believe in the strength that comes from within, in igniting from within, as you well put it, especially when it comes to leadership. You cannot teach someone to be a leader. You can teach skills. You cannot teach leadership itself. The skills will lead this person if they have this spark from inside to become a leader. I often said to women, never wait to be handed permission. When you are convinced, when you have a truth, when you have a purpose, when you want to create a path, you don't need permission. And I'm not here distinguishing men or women, but because I live in a region where we are still on the way of developing the role of a woman, I have to say that we don't need permission. We just need to use this ignition that comes from within to pursue our mission, to go in life with a firm purpose. Because in our region, unfortunately, resources don't just fall on your lap. You have to really dig. And if you hesitate, you will miss on opportunities and you will get unserved. I have to say that in the first years of DiaLeb, even with my determination, with my heartfelt mission, and I had it very clear what's my purpose in life, as I mentioned earlier, I waited to the point where I didn't see it simply as a detour, but as a new path in life, a new road completely. So often I would wake up at night to think about how to do an awareness campaign and take notes. Or many times I would have never-ending conversations and meetings to convince people, let's do this, especially healthcare professionals. When it's a new NGO, people fear maybe that the momentum will pass. Oh yes, she has a daughter living with type 1 diabetes, until they discover, yes, that was the main push. It was definitely the main reason. But when I started seeing the cases we have in the community, when I started seeing the impact of DiaLeb's programs in our community, it wasn't anymore one reason. I had already thousands of reasons to go on and continue. And if I had to wait for the perfect conditions, they may never happen. So that's why I say, we don't need permission. We have to pursue what we feel at heart is our purpose, is our mission. And mine was to help people with diabetes, and all of us at DiaLeb. Of course, having Sylvie amongst us was the greatest push. I know many of our members look up to her. They see her as a role model. But you know, the philosophy, let me say, of igniting from within that I always had, I always thought about it, I always felt convinced that I have it. It made me resilient, and I think it shaped me to become a creative leader, not just to feel leadership, but to be a creative leader. But I have to say, this alone is not enough. Feeling this self-confidence, the determination, the purposeful mission is not enough alone. It needs support, it needs partnerships, it needs mentoring, it needs a whole ecosystem. So for women to become leaders, the whole ecosystem needs to be supportive. There needs to be mentors. We need funding and flexible funding, because we know the types of funding, especially nowadays, are very competitive. And we also need policy changes. Some things cannot be done unless we change the current policies in order to adjust. And all of those components will help us to reduce the structural barriers that we often feel. So the internal drive, let me put it in a simple way, it starts the fire, but the alliances keeps it burning, and you need it to keep burning. And for it to be sustainable in the leadership scope, let me say, you need to blend the personal mission and purpose with the collective support. And this is why I take it very much at heart to mentor young women in advocacy, in health advocacy now, because I do know that one encouraging voice can keep the fire alive for a long time. And it gives me, let me say, great satisfaction.
Thank you so much. I truly believe that not only in diabetes advocacy, we create the chances. The chance and the opportunity won't come to ask us to do something. We have to create the opportunities. And it's an ongoing process. As you said, even if you think that you're a safe space, you still have to keep on going, keep on creating things, keep on interacting with people, because as diabetes evolves, advocacy evolves, and the needs of people with diabetes continuously change. And I want to connect this to the next question, that funding and sustainability are the most great issues when it comes to diabetes advocacy. I know you've done a lot from the place you sit and from the power and knowledge you have, but if every stakeholder or founder could hear you for the next hour, what message would you pass when it comes to the cost of neglecting diabetes?
Here comes the serious part of it. When we talk to financing health, we have to be realistic that diabetes often competes with flashier crises. If there is a flood, people forget diabetes. If there is a war, people forget diabetes. If there is any emergency situation, diabetes comes to a second grade of urgency. But this actually has not simply a cost, it has a huge cost, and it has a big toll on what comes after. When the aftermath of the emergencies start, we start regretting, why didn't we do this? Why didn't we do that? This is why there is a lot of talks nowadays about preparedness. We know you're never prepared for an emergency. You're never prepared for an earthquake or a flood or a war or anything. But at least we think of readiness, of having the basics, because who suffers the most in those situations are the people with chronic diseases. So we do need to think about it. But every economist would tell you that diabetes quietly drains the budgets, because you look at dialysis units, you look at amputation, you look at blindness, and all of those are the sad part. They are preventable. So the cost is not materialistic. I wish it were only that. I mean, if you look back to the coronavirus times and the aftermath of it, how many people suffered from complications of diabetes that would have been easily prevented if they had maybe more knowledge, if they had more care during those times. It hit us all, but the people who paid the highest price are the people living with diabetes and NCDs. And this is, everyone knows that. So when you see young adult losing a career, for example, because of complications, it makes me very sad, because they had inadequate care, they didn't have enough care. Or when you see a family going bankrupt because they cannot afford giving all the care that their son or daughter need to treat their diabetes in a way that it is well managed. As you mentioned earlier, giving the bare necessities is not providing access or care. You mentioned that it's really important what you said, because sometimes big organizations think it's enough to provide the strips and the insulin, but it's a whole set of components to create a proper care for people living with diabetes. But let's go back to the financing. And living where I live in Lebanon and in the Middle East region, I know a thing or two about humanitarian settings, about the need of people living with diabetes or any other NCDs. I've seen it happen. I've witnessed very unfortunate situations that could have been preventable. And for that, if I were to address the funders, I would say empowering the local NGOs is tremendously beneficial in those cases. Big international NGOs are doing an amazing job, and we appreciate that. But when they come to a local setting, they have the barrier of language, the barrier of not knowing the culture of the people. So if funders looked more into empowering small local NGOs, they would do an amazing job in serving their own communities. So this is one. And if I had one uninterrupted hour with global funders, not at a local level now, I would really tell them that ignoring diabetes is like ignoring the big cracks in a dam. You don't know how much it's going to cost you until the flood comes. So let's not wait for the flood. Let's prepare ourselves and invest in access, invest in education and prevention today, not tomorrow. As the NCD Alliance says, the time to act is today. It's now. And this way, we can prevent disability, we can prevent amputations, we can prevent all the complication, the unwanted complication that no one wants to get to. And they are expensive. It is much more expensive on a government, even in the developed countries, to treat or dialysis, to treat people with kidney failures, than it is to treat someone with diabetes and to help them manage better their diabetes. Let's not look at it as expense. Let's look at it as an investment in a healthier community and also in a cost-effective policy strategies. Exactly, if I were to say it in one sentence to the funders, I would say that diabetes funding is simply a down payment on a healthier future.
Exactly. Prevention is much cheaper than having to treat the complications. And also, when it comes to complication, isn't only the cost of having that patient in dialysis, it is the cost of patient not having the ability to fully work, or not having the ability to walk properly, or to drive a car, or to have a good social life. We talk about the whole image of complications, which is really costly in terms of the quality of life of a person living with diabetes. It's not just the cost of the treatment, which is really high. It's the emotional barrier as well that those people experience. So thank you very much for the perspectives you brought to our conversation. I will now leave you for a bit and I will go to Sylvie. I will start by highlighting that you have a background of policy, economic, social change. I know that you work in the Qatar Foundation. I want to ask you how these experiences and the knowledge you have has changed the way you think about how systems reforms, especially when it comes to diabetes care.
Sure. Thank you so much, Konstantina, for the question and for this engaging discussion. We're shifting gears a little bit, but I think one area that I wanted to highlight is that I sort of have the trifecta of work experience from the public sector to the private to the international and nonprofit, so IGO and GO sector, whether it's through my work, but also through founding and co-founding DiaLeb and through developing the needs and the systems that we had to operate and provide impact through our own NGO with Jackie here. So the key realization that I've had, to be honest, is that when it comes to issues like health, particularly NCDs and diabetes, these are what we call in the policy world wicked problems. These are problems that are not only multifaceted, but they're also multisectoral. And as such, they require different levers working at the same time. So this is what we talk about when we talk about systems change. So far too often you see that policies and regulations related to diabetes are relegated exclusively to ministries of health or health functioning entities or national health agencies for hospitals. But we know, and you yourself, like myself, know that diabetes is not just a health issue, it's a lifestyle. So people living with diabetes require holistic support at all levels. And to prevent diabetes, you require holistic policies that look at the whole life cycle. So for example, when we talk about healthy lifestyles, we talk about walking more, right? Sedentary lifestyles has become the recent pandemic. It's leading to obesity, it's leading to higher diabetes instances. So how do we encourage people to walk more? Is it the Ministry of Public Health? No, it's the Ministry of Public Works, for example, that has to build parks, better sidewalks, walking lanes, because a lot of cities maybe don't have that, shading because it's too hot in the country where you live in. So it's about a collaborative approach to really look at that ecosystem framework to the issue and the wicked problem at hand. So it's how do you achieve that collaboration? And, we've already touched upon that in the beginning, and it's not easy, but it can be done. So you see all of these new movements like, the NCD Alliance is a combination of not just health practitioners and experts and doctors and policymakers, but you have people with lived experience. You have people who work in engineering. You have people who work in civil society. So it's about those empowering those cross-sectoral and multi-sectoral entities to really work at the same time and alongside each other. When I was first diagnosed with diabetes, the first thing that I realized was that information and access to information was not just limited for my context and my region, but a lot of it was also contradictory to my own lifestyle and my heritage. So it came from either a Western approach, or you had the American Diabetes Association, which has fantastic resources, but there are elements that may not apply to a way of life in different countries. So having the ability to also create, contextualize, localize educational materials and information in languages that people can easily understand is also very important to achieve success. So ensuring that our policies are not just collaborative, but also not a copy-paste, right? Contextually driven, localized, built on the needs of the people that you're trying to serve by ensuring that you're putting them first. And this is where the engagement of people with lived experience and people living with diabetes and other NCDs becomes critical, because only then when you engage them, when you put them at the table, do you know what the needs really are. So this is something that I have been advocating quite strongly for, that I have been trying to apply not only in my work through DiaLeb, but also in my professional career through the work that I do in my policy advocacy journey.
Again, you give the whole image of how things work and how, I say, what's happening behind the curtains, because we hear many promises, but to actually change some things may be really difficult, but sometimes the change is quite small and affordable. There just needs a person in the table who proposes the change. You, like me, live with type 1 diabetes, but you're also a policymaker. So there are two different roles, and how those two interact and align, and where do they disagree or crash? How do you experience that?
Really about improving the lives for people in my particular case. And with the work that we do at DiaLeb, it's about improving the lives of people living with diabetes and other NCDs. And as a patient with lived experience, I can give firsthand account. And this is why when we were speaking about DiaLeb and its mission, I had really a very heavy hand in ensuring that the programs were based on what I know as a patient, but also what I had engaged with other people living with diabetes and other people in the ecosystem and other caregivers and other healthcare practitioners to really understand, okay, this is my experience. Does it resonate with you? What are other angles that I may not be aware of myself as a person living with diabetes? How can I ensure that we're being holistic and comprehensive in our coverage of the programs that we're putting in place? What is the priority? Right? What do we need to tackle first? So issues like mental health came up, issues like stigma. This is where we decided, okay, we need to really have patient-focused support groups where we can not only bring the people living with diabetes together so that they can exchange experiences and knowledge and just support each other along this journey. Because as you know, sometimes it can be very isolating for the person living with the disease or living with a non-communicable disease, because it's unseen by nature of NCDs. It's something that is unseen, it's unfelt by anyone outside of the person living with it. So having that ability to connect, to create those safe spaces, to find others that you can look up to, or to find others that you can complain with and will understand your complaints because they've lived through it and know exactly what you're talking about, really became really powerful. So I think we developed one of the first networks of its kind for particularly adults living with type 1 diabetes. It wasn't available. And then we sort of started branching out into having focus groups for caregivers, for parents who also need that support, right? Who also need to be able to exchange without their children being there, be able to be quite honest and quite supportive with each other about the struggles and the balances and the thoughts that may not want to say out loud in front of their children. So this idea of having that person with lived experience first allowed us to really develop those programs that then led into very effective, what I hope is very effective impact on the ground. Also, it's about understanding that as a person living with diabetes, the toll of managing chronic disease is quite heavy. And imagine adding on to your day-to-day stress of having to manage. Right before this call, you were checking your glucose. You were saying, maybe I may have to take some juice. This is a day-to-day, minute-to-minute struggle that people living with diabetes already face. Imagine adding to that the stress of not knowing if you can purchase your insulin, or if there will be insulin available for you, or if you are able to afford your glucose meter, or if you can keep your job because if somebody finds out, you may be stigmatized. So being able to work towards changing those stereotypes, advocating as Jackie's doing with her role as National Diabetes Federation advocate and NCD Alliance advocate, making those voices heard, giving us a seat at the table to say, we really need to ensure that insulin and glucose monitoring equipment is seen for what it is. It is life-saving, necessary equipment. It is not a nice to have, and we should not be burdening people living with diabetes with this disease. So this is where, it comes together quite nicely, because I'm able to give my firsthand account into the programs and to support. I think the clash becomes when, with all policy change, there's time, there's bureaucracy, there's delays. Sometimes you take one step forward, leadership changes happen, and you go 10 steps back. And I think that is the biggest frustration, particularly as someone who really is all about making change and solving problems. And I see really the potential of what one small change can really do for people living with diabetes. And then the unfortunate nature of just how long it takes to do that one change. I think that's where as you're calling it a clash, to me, it's more of a frustration. But I think it's important to keep a positive outlook and to always keep working towards the cause. One particular instance, for example, that I can mention is when we had the financial crisis in Lebanon around 2020, 2021, that led to also a shortage in medical supplies, and the government was looking at establishing what they considered a priority list of medicines. So after doing our work, we realized that insulin wasn't on that list. Can you imagine? So, okay, we're making sure that everything is provided for, but insulin is a nice to have. So here's where we were able to, take that frustration, channel it into energy, and created advocacy groups and created a very strong advocacy campaign with our support, with our volunteers and our community of people with lived experience, where we sent people living with diabetes to speak to their constituents, to their ministers, etc. We sent letters, and we were very active with the healthcare professionals as well to ensure that insulin made it on that list. So it could be seen as just a small tick the box. Okay, we ticked insulin from a list of many medications, but that small check, despite the effort that it took, the reward was definitely life-changing for many people in the country.
That's the power of advocacy, from being an ongoing process, but also reacting to how reality changes in each country. So having built a strong advocacy level and team makes you more able to react when the crisis comes, because you have a standard of people who are able to work towards the change that we need. You have described yourself as a positive impact maker. And I would like to ask you if there was a time that it was difficult to keep that optimistic view, and that you had to challenge yourself to keep optimistic and to have that positive approach toward advocacy.
I mean, of course, it's challenging. As somebody living with diabetes, I'm sure you face this yourself. You have your good days and you have your down days. And I think the most important thing is to not let the down days become what define your journey. There are always going to be challenges. There are always going to be frustrating moments or instances where you feel that you're losing despair or hope. We had so many examples in the last few years with the crises that affected Lebanon, whether it was the Beirut blast, whether it was the war and the internal migration that ensued because of it, and making sure that people living with diabetes were taken care of, that their medicines were supplied, that they were able to manage their existing condition while also managing the unimaginable conditions of the situations that they were put under. And you see what's happening in the world today with Gaza, with Sudan, with many countries affected by conflict. And then you have natural disasters like the recent Pakistan flooding, which have been horrendous, the earthquake in Afghanistan. My first reaction is always to think about the poor people who have lost their livelihoods. And yet, imagine if you have that additional stress of having to maintain your insulin in a refrigerator when there's no electricity because you've just been hit by a natural disaster or because you're living in a tent. So it's those moments where it can be really sobering and where you may feel like all hope is lost and khalas, there's nothing we can do. But here's where you really have to remind yourself that it is a journey, that if you can help one person, if you can make one person's life better, you've done your impact in this world. And that there's always, in these cases of crises, in these cases of extreme challenge, is always where innovation comes. And it's always where you start to really see the good nature of people and the true champions and community-led NGOs. Really, you see the community itself bond together. We would not have been able to supply the medication to those who needed it, right? It was word of mouth that let us know this person needs this. I know this person who doesn't have electricity. Please, we need to keep their insulin in a fridge somewhere. Can you help us? Or this person has lost their home. It's nothing. They don't have the ability to take care of their children. They have 2 children with diabetes. Can you please help us? So this is where that community and finding those champions on the ground really reminds you of the true good-hearted nature of people and really reminds you to stay strong for them, right? Because at the end of the day, we are all connected in our humanity and we are all connected in our awe of life. And if we can do one little thing to make one person with diabetes have a better life. We had a situation where we helped, I think it was a lady living with diabetes tell her future in-laws that she was living with diabetes because she didn't know how to do it on her own. So having that support and knowing that you supported them, and when they see that she had other ladies living with diabetes around her and it was fine and they've been married and they've have children, it just created that sense of, oh, okay, it's going to be fine. Let us know how you can help, as opposed to what could have been quite a difficult discussion and maybe even a non-continuation of that engagement. So it's really, you have to remind yourself and find those glimmers of hope and remind yourself that it's not all lost. Stay positive, but also there's lots to be positive for if you're really looking for those nuggets of sunlight or those nuggets of inspiration.
Nowadays, we tend to feel that we are isolated. We do things on our own. We do our job, we do our family, and that's it. And we forget that we are part of a system, and connection is what makes our life easier. There's a story, I don't know if it's international, but there was a fire and a small bird kept bringing water to the fire to eliminate the fire. And they asked them, why are you doing this? And the bird answered, that's the maximum I can do. And if that's my way to help, I want to be okay with myself that I did what I could to save, because I belong also in this system that is being burned. So that summarizes, we all can contribute in our way, no matter how big or small. Things always start small. Even a marathon starts with a step. And then there are 42 kilometers, but the beginning is that one step.
Definitely. And I think, a lot of people sometimes, particularly in the nonprofit world, we tend to look at the big challenge. And then sometimes you're stifled by the grandioseness, just how big the challenge is, and you don't know where to begin. And like you said, marathon starts with a step. Just begin where you can. That impact is already 100% better than no impact. And when you think of it that way, it really stimulates the ability to and the impetus to start doing something, no matter how small. And then you have the ripple effect over time.
It's always important to keep that in mind. It applies to every sector of our life, even in advocacy. And I will take you through to the experience you have while have lived in many countries around the globe, how this has shaped your perception of the challenges people with diabetes face, but also the challenges of each healthcare system, and how you adapt your advocacy through the region that you live.
It's interesting because I think that multicultural lived experience also enforces the need, as I mentioned earlier, for contextualized solutions, right? So we have this tendency to always look at best practice, as we call it in the policy world, or look at benchmarking. What are others doing and how can we copy it for our own needs? And while there is benefit in that, and there's a lot of value in learning lessons from others who are doing things that may be working, those have to always be taken with another layer, which is that grain of salt that you look at things with and say, okay, but in my contextual ecosystem, right here, we have, for example, public healthcare as opposed to the American system, which is privatized healthcare. Whatever policies are working there will not be working here. If I look at dietary guidelines, you have to look at what is the heritage, what is the cultural norms, what are the diets of the people in the region that you live, what are the natural vegetables that grow there and the fruits, what are the seasonal elements. Like, you can't just say, okay, you have to eat poultry. What if poultry is not readily available? There has to philosophy? What if we're in an island? Then it becomes, fish recommendations, for example. And then you also have your cultural ways of life, because you can give guidelines, but if it doesn't match with someone's way of life, it's not going to be helpful. So a lot of events, as you know, in our culture are expressed around food. So we have to be really nuanced into understanding that, okay, we can tell one person don't eat carbs, but if every event is like this carb loaded meal, as you know, every Western birthday is basically burgers, fried food, cake, which is a nightmare for anybody living with diabetes. So how do you adjust that, and how do you develop options that are actually not excluding the person living with diabetes from having to say no, 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 nothing, but from sensitizing the community approaches to say, okay, why don't we have a fruit platter always, just in case there's somebody who can't eat that, or making different options and looking at ways in which we can adapt what those behaviors are, working very closely with the people and their lifestyle. We've all said without diabetes or with diabetes, but we've all gone through that phase where we're like, okay, I'm going to start a diet on Monday. You download it online, and then 2 days later, you're not on the diet. It's because it's not tailored to your lifestyle. You can't keep it up. So it's the same with these things. Now, when it comes to policies about health systems, I think there's a lot to be said about community health and the need to really look at how are the policies allowing for those community health factors to be enhanced. We've learned that centralizing doesn't work, because you really need to reach those communities in rural areas, not just those in urban areas. You need to be able to reach communities who are at risk, maybe in refugee populations, and you need to be able to do so, as I said very early on, in their language, in terms that they can understand. So here's where the policies come in place on how you translate guidelines, education, and awareness, and how you allow that awareness to take place. So if you're going to wait only for a doctor to be able to give the information, you're going to reach very limited number of people. There's only so many patients a doctor can take per day. But if you enable diabetes educators to go out into the community and promote awareness and work with your local NGOs, as Jackie was mentioning before, your impact can be really amplified, and your prevention, so moving the needle from preventative, from just healthcare to health prevention and holistic well-being and lifestyle approaches, we can really not just reduce costs, but have better outcomes for all. People will be happier, they'll be more productive, you'll avoid complications. I mean, we know the science and we have the technology. So why aren't we empowering people more to make better decisions and to make better lifestyle choices? And we know that kids need to exercise. Why are there still schools that don't have physical education in their curriculum? So these are the small things that we can definitely build on, and where we can definitely adapt to countries and contexts, but also push for independently.
I think Dr. Jackie has to add something.
I would
Please do.
actually like to build on what Sylvie said in relation to this last questions. Having lived myself in different continents and having been in contact with different community, one thing I really loved about being on the board of the International Diabetes Federation is that every couple years the Congress is in a different country. But furthermore, we as a board, we were holding our meetings in different continents, and we were having meetings with the local NGOs. This really was a deep lesson to learn about how different it is from one place to the other, and even in the same country, from the rural areas that Sylvie was just mentioning to the big cities. This was very enriching. And I want to tell you a small thing that happened with me, where I have visitors from Australia, my sister and my niece, and I took them to the pool. And while we were at the pool, I saw a young lady with a sensor. Well, of course, I wasn't going to simply approach or talk about that, but they were speaking Spanish. And having lived in Ecuador, having taught even Spanish, because I hold a teaching diploma, and it gave me this facility to start speaking with the mother. Oh, where are you from? What do you do? And then we came to the conversation. It turns out they didn't know there is a diabetes organization in Venezuela where they are living. And through my connections at the International Diabetes Federation, I was able to give them some contacts with different associations from Latin America, where they speak the same language, they have the same cultural traditions, and I felt so good about that. So this gives you an idea how important it is when you have a multicultural background, when you have knowledge in the topic, when you have experience on how to approach people. And this might be a very, very minor detail, It just gave me happiness because I was able to serve one person, to help them with connection. It really made me feel good, and it makes the point of how important it is to network, to transmit the knowledge, not to be selfish with what you know, with the information you know. Put it out there, let it help other people. I think this is a big lesson to all of us, to really open up and to transmit the information, the accurate information. Many times I say, I don't know. Let me find out. It's not a shame to say, I don't know. I'm not supposed to know everything. You're not supposed to know everything. Even having lived with diabetes many years, there is so much you don't know about it. So at the same time, where I encourage people to network, to transmit the knowledge, to pass on the right information, have the courage to say, I don't know about this. Let's find out together. Let's ask a professional. Let's do this. It's really important.
Yeah, that cross-border knowledge of the landscape of diabetes globally is so important. I was born in Greece, I'm Greek, but I was raised in Belgium, and diabetes found me at the verge of moving from Greece to Belgium. So in Greece, our foods are like yours, like carbs, but also vegetables and everything mixed up. And in Belgium, the plate is divided by 4. So they were like, these grams of meat, these grams of carrots and potatoes. And I'm like, my food has it all, and I cannot exclude the ingredients to eat each small piece of meat. And that was so difficult because my parents just couldn't continue cooking in Greek while measuring and calculating by the plate. Now it seems funny for me, but back then that was a real struggle because the treatment and the way we approach diabetes changes from country to country, from that divided by 4 plate to our plates who are, I don't know, they're a nightmare for dietitians and nutritionists to count the carbs. I think we just count, then we pray, and then we bolus, and let's see what comes after. So yeah, I had that difficulty of expressing how our culture works and how in Greece, like, we eat all day long, we don't have 5 meals per day. Another topic to discuss, but I could not even explain to them that we don't have that strict 5 meals per day rule. We eat all day long. So yeah, I truly understand that it's so different from country to country, like to calculate a burrito from calculating a burger.
Or a shawarma.
Yeah. Don't come even to the Asian cooking or the Indian ones. Again, simple rules just do not apply. And that's something that also healthcare professionals have to keep in mind, that the lifestyle is so different. I want to combine you both now. I will do 4 short questions. The fact that you both are co-founders of DiaLeb. What moment do you realize that DiaLeb is not just an organization, that the work you do actually changes people's lives? And we want to highlight this because often people see that over information of organizations and posting and stuff. What's the real essence of why we do it and why we continue to do it for so many years?
If I can start with that, when we initially set out to start DiaLeb, there was a real gap I had identified, which was that I could not find others in my situation. I could not find others who knew about diabetes in the region in the way that I needed it to be able to have, that fulfilling lifestyle with adapted tools for our culture. There were other NGOs in Lebanon at the time that focused on children or focused on exclusively looking at type 2. So we identified the need for having that adult type 1 group that I mentioned. Hard at first. I think it took us a few years and we only had like 3 or 4 members, but now the members come to us. And that is, I think, the ultimate validation of the work and the impact that we're having. People come to you and ask to be part of your patient support group or advocacy network, or they want to just volunteer because they know that they can meet others and they know that you're having impact on the ground. And I think the second one is, of course, the people living with diabetes themselves who are coming to us, etc. But the second point was that I've always been a believer in volunteering and community work. There were many who did it, but they did it in specific ways. It was usually like with the Red Cross or with Scouts, etc. We didn't have a culture of having civil society NGOs that provided, for example, internship to graduate students or undergraduate students. And that was something that I was very passionate about developing so that their internship could be considered, even if it was at a nonprofit. And now we have several internship programs. We've had several interns that have come partnered with universities to sort of make it part of the accredited institutions that they can do internship with. So it really validates the role that, yes, you're a non-for-profit, but you're a social entrepreneur at the end of the day. We are an entity that can provide valuable business acumen to any intern, valuable knowledge of how to create social enterprise. So I think that has been the 2 examples I can give where we see the validation of our work.
Sylvie said it perfectly and in a very nice way, how we can know the impact. There are many ways to measure, but I'm not talking science here. For me, sometimes a word from a lady in a remote community who comes to me and says, I follow you. I see the information you post on social media. I watched you on TV when you came out with your daughter and you spoke so nicely. My daughter looked at her like her idol, and she hugs me. This for me is equally or more important than all the measurement tools for impact. This on one side, but I want to stress on the internship that we offer, because when a renowned university or when 10 renowned universities in a country sign an MOU with DiaLeb to send their interns or to do remote internship or to assist in our awareness or to design, like they can be studying engineering and they want to know how to do an awareness campaign from A to Z. This gives me a great satisfaction on a personal level, but furthermore, it validates our works and it shows us how we are creating a bigger impact than we possibly can know sometimes. One more thing I want to say, more than the people living with diabetes themselves coming to us, when we started getting referrals from doctors calling our office saying, this is someone I'm seeing recently diagnosed with type 1 diabetes. We need your help. He or she, they need to attend your support groups. Please focus on 1, 2, 3. It's telling us that we complement insulin. We complement the treatment. Treatment by itself is great. It's much needed, but the holistic approach Sylvie was talking about is what we are offering at DiaLeb. And when doctors started referring the people to us, this is how we know we are on the right track. But believe me, we know we are far from our goals. We are on the way. We keep evolving. We keep updating our strategies. We keep updating our programs. We keep looking for what's needed to answer the needs of our community. But we know we are on the right way.
I can add also, we strived very hard from the very beginning to find the international partners we would want to work with. That was very intentional because we understood that you need to strengthen numbers. I started very early this conversation by highlighting the need for collaboration. So yes, we found those other civil society NGOs in Lebanon. We're very connected with them. We know them well, but there's a lot happening internationally. And it was through those connections, we became one of the first accredited diabetes schools, I think, for the International Diabetes Federation. We became members of the International Federation and brought other partners along to better represent our country. Having mom elected as a vice president was a very defining moment because it was like a recognition of the work that had been done through DiaLeb, as well as obviously her personal capabilities and abilities. But that would not be without that backbone, which is the association and the work that we do at DiaLeb. And it's through now those collaborations and those memberships and those roles that she's not able to take the needs of patients living with diabetes in Lebanon and in the region to the global agenda through attendance and having a seat at the table for the high-level meeting, for example, in New York upcoming, where she will be representing our needs and our voices, to the WHO Global Compacts, to Geneva annual meetings of the WHO and more. Yes, of course, a lot remains to be done, but there's something to be said about what we have achieved since we started in, 2011? So it's almost 15 years next year. It's been by no accident, as I like to say. It really has been intentional, but it also has been because we've always had, as Jackie was mentioning, the community at heart. It was always meant to benefit the community. And we've always tested that hypothesis time and time again through our engagement with our community.
Yeah, and also that's why IDF so insists and supports the local organization, and each representative needs to be nominated by a local organization, because the global meeting once per year or twice per year for every advocate, but the work has to be done locally. There are many ways to evaluate how much you do without being as strictly and tough or something like that. Can be measured in different ways. You've already mentioned both that you live in a geographical area that faces many dangers and issues. In such period, how effective these organizations work, and what is a lack of a strategic or planning process?
You give a simple example, which was the plate. So having the ability to advocate that we need our own locally driven metrics for what nutrition guidelines are is one way to be really authentic. And we have worked with the nutritionists across the country, and we realized that was a gap in terms of when it comes to particularly people living with type 1, because you have your general, the rule book, this is 15 grams, this is 15 grams, but nobody's looking at the difference of what those grams are. Nobody was looking. Very rare was it to find somebody with understanding of a glycemic index, of the difference between something that's whole grain, something that's white, something that's brown, and how that affects your blood glucose. So we worked very hard in the beginning by providing what we called advanced carbohydrate counting sessions to nutrition students before they graduated, so that the nutritionists, if presented with a patient with, or if they had to treat that was living with diabetes, would already know that there's a layer more complex to the diabetes management, that it's not just here's a piece of paper that tells you the number of grams of carbs and you're good to go. We've been working a lot with sports experts and putting guidelines of what it is for, specifically for sports with diabetes. Like I mentioned, this is something that has to be done really based on the context and the region, because how active a population is very much determined by its culture, by its heritage, by what's admissible, what's not. It's one thing to tell people, okay, you have to exercise every day, but if you don't provide, for example, safe zones for females to exercise in a way that is socially acceptable, what can they do? So you have to be very in tune to what is needed at the level to be able to really authentically advocate. And I think there's a lot has moved, and I think here's where technology has actually been a positive. So these glucose sensors that we wear, you and I, have allowed us to learn very quickly what spikes blood sugars, what happens, to also start analyzing trends outside of just food and bolus of medication, right? I really have a lot of hope for what that will mean moving forward, because I think that this will really revolutionize the way that we see dietary guidelines, for example, particularly in periods of fasting. So a lot of cultures have fasting. It was before like unconceivable, seen as a no-no, but when you wear a device like this, you can actually be quite in tune and actually try to do what you want for your religion, for your faith, for your culture, but also take care of your health. And that allows us to be more targeted in our approach and in our guidelines. And then when it comes to your other part of your question, which is about the region and the volatility, we held a session, I think it was 2 weeks ago, I can't remember, where we spoke to experts, a doctor from Palestine. We had the Mita Zindani Foundation in Pakistan, who's supporting people with the floods. We had a doctor from Lebanon who's been dealing with refugee communities. And the conversation was very simple. It was really to say, we cannot forget about the needs of people living with diabetes in the times of humanitarian settings. And I think this is critical. We are living it acutely in our region, but this will only get worse as climate change becomes more abrupt, as more insecurity embraces our world. So highlighting the need for those protection mechanisms, the need to put the needs of people living with diabetes first is key. And this is where the role of advocacy that we were talking about becomes essential. So at the high level meeting that's happening on September 25th, one of the demands of civil society and people living with diabetes has been that you have to put diabetes at the forefront of the NCD declaration, and to really make sure that in humanitarian crises, NCDs are not neglected, and particularly diabetes. So when you send food relief, don't forget the insulin. Don't forget the necessary medications for people living with diabetes.
I don't think there is much to add to what Sylvie beautifully said, just to say that, yes, it's going to be me who will attend the UN high-level meeting. I will be there. I will be speaking at some of the side events. But as Sylvie said, I'm there because we, both of us, founded DiaLeb, because we made the impact. Because of that, I was elected vice president and re-elected vice president. Because of that, IDF appointed me as their representative on the board of the NCD Alliance. So nothing is Jackie. It's because I'm the co-founder and president at DiaLeb, because of the long years of experience, because of the trust and credibility and validity of our work. This is like the validation. Come share with us what you've done. And this is due to the multiple MOUs we have signed with international organizations. But let me go back to the humanitarian settings and give you a very small example. When the unfortunate Beirut blast happened on the 4th of August in 2020, everyone knows it's the biggest non-nuclear explosion that has ever happened in the history of humanity. And it was really a terrible situation. Our team was it happened in the evening of the 4th of August. Our team, volunteers, were on the ground, including myself, my youngest daughter, And many of the people living with diabetes, we were on the ground, stepping on the broken glass, on the debris, and visiting people, taking notes on papers and seeing their needs. And the very next day, we would be there again, remembering where we saw this lady, where we saw this young man, to give them the medication they needed. Of course, due to our credibility, our years of experience, people supported us, people donated to us even without asking, because it was a very unfortunate situation. But that's why I speak about empowering local NGOs, because we are at the forefront. We are the soldiers on the ground. And yes, we have what it takes, but we need more empowerment in order to continue. Because as I mentioned, you can try to be prepared, but you can never be ready for a disaster. You can only try.
You stand there for DiaLeb, you are the representative. I see that you know that the voice that represents so many people, and I think that you don't stand there as Dr. Jackie, you stand there as a person who speaks out of her knowledge, her experience with the interaction of the people that need you to be there for them. So that's quite important. And also being in the front line when the disaster happens shows the quality of leadership. So much appreciation and being humbled by the way you stand for the things you work for. Two combined questions. I want to say how you experience your roles as mother and doctor and collaborators in the diabetes world and DiaLeb that you founded. Also, if you had to leave a world, a message through DiaLeb while passing the torch for the next generations, what would that message be?
For many years, I wanted people, when I said my name, to think of DiaLeb. And even if I didn't want that, it was what it was happening on the ground in reality. But then I understood that even if I am the face coming forward, if I'm speaking, there is a team, there is ideology, there is a strategy, and there is a community behind DiaLeb. So I understood that I can still do what I'm doing while empowering other people, thinking of sustainability, thinking of continuity, thinking of the leadership being transferred and transmitted, and thinking of intergenerationality, like having young people collaborating with me. They think they are learning a lot from me. Maybe true, but they don't know how much I'm learning from them. So when you understand that, you don't stop thinking or identifying yourself with the organization. All the opposite. You do that in a much stronger and firmer way, but at the same time, you start empowering and you start delegating and you start feeling happy when somebody else does a great job, without you being there, looking at pictures of something happening. I think not many people would have the courage to say that it took me time to feel happy when an event was successful without me being there. I think Sylvie, being my daughter, knows a little bit about this, but I have no shame in admitting it, because I understood that when that starts happening, it's the effect of my own leadership, and it should make me happy that there is continuity, and there will be continuity in this leadership, and even stronger, and that the diverse ideas, even if they might be opposite, can only give richness to the organization. So my message would be, we've gone far in our advocacy journey, in our policy journey, in our programs journey, in creating something good for our community. But I believe there is a lot to be done. And I believe those who are now benefiting from everything that's already said by Sylvie, by many professionals, by myself, will really take the lead one day and continue even a better work than what we've been doing, maybe.
I think I can just add by saying in every team, you have to have diverse perspectives and you have to have diverse styles. And I think it's quite obvious that you have different strengths in each of us, and we built on each other's strengths. When I'm faced with a challenge, I go into a technical understanding of the challenge. I sit in my thinking corner. How can I solve the problem? How can I solve the problem? At the same time, she would be out there finding partners for the problem. So it accelerates the speed at which the programs get delivered, they get put together. We each have our own skills and our own ways of thinking about things, but also we each have the networks that we brought. That appreciation really leads to a very unique, agile way of working, and also agile way to adapt to different crises and to different challenges, and to identify funding sources, which, as Jackie mentioned, is not easy. And that's her strong suit, maybe not mine. I'm happy to write the proposal, but someone's got to go talk to the funders. So it's how we balance all of that. You learn from each other as you go. So over time, I've become a lot more confident speaking up and being outspoken, and vice versa. When it comes to the legacy, for me, it's about a world without stigma. So where there is a genuine understanding that people are living with diabetes not by choice, no matter what type of diabetes it is. There are genetic factors, there are lifestyle factors, there are socioeconomic determinants of health. So people who were born in a particular economic situation with a particular understanding from the community in which they live are not at fault if they grow up living unhealthy. And then, putting that blame on the person is ill-placed. It's not right. And it just means that we need to do better as a society to make sure that everybody is given the basics health access, the basics education access, the basics to healthy living. We cannot expect people who are born into living quarters with no access to green spaces, no access to healthy food, to then come up and live healthy lifestyles. We cannot be blaming them for the type of diseases that they may end up living with. Policymakers need to do more to really understand their share of the burden and how we can ensure that equitable playing field for everybody, to remove that stigma, to really talk about the needs of health prevention and really holistic approaches to healthy lifestyles, and not just looking at it as, okay, you need insulin, check, you need a pill, take this pill and go away, live your life. We need to go one step back. We need to really flip health care on its head, because it's really just health promotion. It's not health care. We're not doing the care. We shouldn't be focusing just on the tertiary aspect of caring for the people once they're diagnosed, but really doing a lot more with community health approaches, with NGOs, with awareness programs, with schools, on the groundwork, to really ensure that we're flipping. It's the only way I think we'll be able to stop the rise of this alarming rate of diabetes rise around the world. That's obvious. Whatever we have going is not working. We know we can do better. And I really hope that we start to see a shift in more empowered NGOs, civil society organizations, community health networks, and really health promotion as opposed to just healthcare.
If I could add that, talking about numbers, the International Diabetes Federation is predicting a 40% increase in the numbers of people living with diabetes by 2045. We are talking about a 40% increase if we don't do the right things. As Sylvie said, obviously it hasn't worked so far, especially that now there is a special attention on type 5 diabetes, the one that was spoken about many years ago and then no attention was given to it. Now that they discovered that it was most of the time misdiagnosed or confused with malaria, or diagnosed as malaria where it was type 5 diabetes, there is now much more attention. So let's hope that with what's happening now, hoping that our effort to include diabetes in a stronger way in the political paper for the UN high-level meeting, in pushing for diabetes to appear in many of the paragraphs where it needed to strongly appear. And we really worked hard since the zero draft. And while we are there, we will keep at all the side events, at any opportunity we have to speak up. We have the responsibility to be the voice of every single person living with diabetes across the globe. When I'm speaking as IDF Vice President, I represent every person living with diabetes, and this is a huge responsibility. I take it very much at heart, and I really want to do what's right in order to minimize the increase in the numbers and to show that those predictions will never happen, hopefully. But we have a lot to do. We have a big job to do in order to make that happen. So let's be optimistic one more time. Although the scenario does not invite us to be very optimistic, let's be optimistic while working. We cannot sit and wait by being optimistic. We are optimistic, we feel positivity, but while working to change what we don't like.
I'm speechless. I would like to thank you both. I think for people with diabetes, this session is a life lesson, but also so educative and informative. And the perspective you brought in your words means a lot to us. I'm looking so forward seeing you or continue the collaboration in maybe other ways. I would like to thank you both for being here. It was a true pleasure. And also DiaLeb for presence of the work globally.
Thank you, Konstantina.
Thank you so much.